welcome to the VCU Department of Internal Medicine Grand Rounds. Just a quick update. We are still in a virtual format for updates. We'll continue throughout the rest of this season. And a couple of housekeeping items. Please make sure that everybody's muted as you enter the session. If you have any questions or need technical assistance, myself and Thomas Bryan will be available in the chat to help negotiate any things. The CME code will be placed in the chat and also available at the end of the session for recordings of CE credits. And lastly, the session will be recorded and available online in about a week or two once we get the link set up. So today's session is sponsored by the Department of Internal Medicine and the Division of Geriatric Medicine. Today, we are pleased to welcome Dr. Hamid Okhravi from EVMS down in Norfolk. Dr. Okhravi is the Alfred Abinas Distinguished Professor at the Glennan Center for Geriatrics and Gerontology at EVMS down in Norfolk, Virginia. He also serves as the Medical Director of the Memory Consultation Clinic at EVMS. He received his MD from Mashhad University of Medical Sciences in Iran and completed his internal medicine training at St. Louis University and Hurley Medical Center in affiliation with Michigan State University. He went on to complete a geriatric fellowship at the Mayo Clinic in Rochester, Minnesota. He is now the principal investigator of 16 active research studies, including the site PI for several national and international pivotal clinical trials. He's the site PI for the AHEAD 345 study, which is one of the first clinical trials examining the effects of therapeutics in preclinical stages of Alzheimer's disease. He's also the PI for the first ever phase 2 clinical trial on the effects of THC-free CBD oil on agitation in patients with dementia. He has a passion in dementia care and has presented at over 20 national and international scientific conferences and serves as a panel at the Alzheimer's Association International Conference. He is a member of several editorial boards for peer-reviewed journals and mentors trainees, early career physicians, advanced practice practitioners, and other health profession students in the area of memory and cognition. And I can personally say that Dr. Okhravi is a wonderful mentor and friend, and we are pleased to welcome you to VCU Department of Internal Medicine Grand Rounds. Thank you so much. We look forward to hearing about Alzheimer's disease and the pipeline. Your title of the talk is New Alzheimer's Therapeutics, What is on the Horizon? Thank you so much, Dr. Okhravi. I'll turn it over to you.
Thank you very much, Dr. Bergman, for that nice introduction. Let me see if I can bring up my slides. So I don't know if everyone has my slides there. Okay. Well, first of all, happy St. Patrick's Day to everyone. So as you heard, today I'm going to talk about the Alzheimer's therapeutics. These are my disclosures, but needless to say that none of the financial compensation goes to my personal account. Everything goes to my institution. And another disclosure is that some of the data that I'm going to present today are quite fairly recent data, and they haven't been published in peer-reviewed journals. So mainly they are from a couple of meetings, national and international meetings that were presented last year. So the outline of my talk is second generation anti-amyloid monoclonal antibodies as a class. I will discuss 4 of them, and I will discuss about the biological effects on amyloid and tau biomarkers. And also I will discuss the clinical efficacy. Then I will move to explain the reasons for modest clinical response related to these class of medications. And I will also provide some information on other co-pathologies, which could be an explanation for that modest clinical response. And then finally, I try to offer some solutions path forward. So as you know, the neuropathological hallmark of Alzheimer's disease has not changed within the last 100-something years since 1906, when Dr. Alzheimer presented the first case of Alzheimer's disease to the medical community. Essentially, that's the amyloid protein that makes amyloid plaques, and those are extracellular. And then, of course, neurofibrillary tangles that are made up of phosphorylated, hyperphosphorylated tau, and those are intracellular. Majority of medications in clinical trials are addressing or maybe attacking one of these biomarkers. So this is, of course, another kind of entity about how Alzheimer's disease develops, and there are quite a few different hypotheses, and the most common one is the amyloid cascade hypothesis. And based on this hypothesis, there's these amyloid protein aggregates that can start a cascade of events that will promote hyperphosphorylation of tau and production of neurofibrillary tangles. And tangles are quite neurotoxic, and they will cause neuronal cell degeneration and neuronal cell death. And as a result, people will develop cognitive and functional decline and will develop dementia. So now, based on this hypothesis, if we are able to decrease the amount of amyloid aggregation, either by reducing the production or increasing clearance, we should be able to block the downstream of production of neurofibrillary tangles, tau and neurofibrillary tangles, and hopefully be able to either prevent or slow down the rate of decline. Now, all of these anti-amyloid antibodies, they really put this amyloid cascade hypothesis on trial. So let's start with these second-generation monoclonal antibodies. So there are 4 of them, as you know, on the left-hand side, aducanumab. And aducanumab, they had 2 phase 3 clinical trials, eMERGE and ENGAGE, that they were prematurely discontinued. And aducanumab, Biogen went ahead and filed for FDA approval and received FDA approval on June 7th, 2021, last year. So I'll discuss about phase 2 clinical trial related to aducanumab and also both phase 3s. The second one is lecanemab, and right now Clarity AD, which is the phase 3 clinical trial, is ongoing, and the result will be hopefully available at the end of this year. I will discuss about the phase 2 clinical trial of lecanemab. The third one is donanemab, and phase 3 Trailblazer trial is ongoing, and the result will be available hopefully sometime next year. And finally, gantenerumab. There are 2 graduates study phase 3 trials that are ongoing, and hopefully we will have the result by the end of this year. So as you see, this year and next year will be very, very exciting to get more results available from 3 phase 3 clinical trials that I'm just explaining here. Now, FDA has put the breakthrough therapy designation for these medications, and I'm going to read exactly what it means. BTD aims to expedite the development of drugs that are intended to treat a serious condition when preliminary clinical evidence indicates it has substantial improvement on an endpoint or endpoints over already FDA-approved medications. I don't think that anyone in this virtual room disagrees that Alzheimer's disease is a quite serious condition. We see that day in and day out in our memory clinic, how devastating that is for patients and family members. However, for the second comment, substantial improvement on endpoints, I'm not sure if that is really the case with the current medication that I'm going to show, because they do have some modest effect. But this is, again, a personal bias, and I'll be very interested to see what other audience and attendees think. So there are some common themes in all of these clinical trials. All of them are double-blinded randomized controlled trials, multi-center and multinational. And the population is mild cognitive impairment, which is the prodromal stage, people who have memory loss but not significant enough to affect their day-to-day function, or mild Alzheimer's disease. And they all have positive brain amyloidosis by brain amyloid PET imaging. So that was the inclusion criteria. So I will present the biological effects if data is available. For majority of them are. So that will be amyloid target engagement and tau target engagement. And then I will discuss about the clinical outcomes. So let's start with aducanumab. So they had the phase 1b/2 prime clinical trial in 2012, 52 weeks trial, randomized controlled trial, 166 participants. And when Biogen had positive results in this study, they moved ahead with 2 phase 3 clinical trials, Engage and Emerge. Both of them very similar, 78 weeks of trial. Again, RCTs, more than 1,600 participants in each of these trials. So let's take a look at the PRIME study, which is the phase 2 study of aducanumab. So what you see on the left-hand side, that's the amyloid target removal. In gray line, that's on the top, that is the placebo. And then we have 5 different doses. And in purple, that's the maximum dose. And you can see a dose and time-dependent reduction in brain amyloid based on those different doses. So by 54 weeks, 65% of patients became amyloid negative. So very powerful medication. So essentially, biologically, it did what it was supposed to do. For that trial, the PRIME trial, there is really no data on the tau biomarker because that was quite early in 2012. So I'm going to skip that and go to the clinical outcome. What you see on the left-hand side, those are 2 clinical outcomes, CDR sum of boxes, which is the memory and function, and then MMSE. And you see the different doses starting from left, placebo, 1 milligram, 3, 6 titration, and then 10 milligram. And in 10 milligram dose, they found statistically significant results with slowing down the rate of cognitive decline. So this study was positive. Now, after that, of course, Biogen went ahead with 2, again, similar studies of Emerge and Engage trial that I'm going to present here. On the top panel, we have the negative study, which is the Engage. And then on the bottom panel, we have the positive study, which is the Emerge. And this is about amyloid target removal. And as you can see, there was a dose-dependent target removal, amyloid protein removal from the brain. And it was much more pronounced in the positive study, as you can see. So essentially, again, reasonably and biologically, it did what it was supposed to do. Now, here's about tau biomarker engagement. So they did the cerebrospinal fluid with phospho-tau. And again, on the left-hand side, you have the negative study. On the right-hand side, you have the positive study. And you can see, especially on the right-hand side, the positive study, there was a dose-dependent reduction in the amount of tau protein in the CSF. So essentially, it did engage tau biomarker by mainly directly affecting the amyloid reduction or removal from the brain. Here's the clinical outcomes for the positive study, the Emerge trial. What you have on the left-hand side, those are the primary and secondary outcomes, CDR sum of boxes, MMSE, ADAS-Cog, and then ADCS-ADL, which is a functional outcome. And then you have the placebo on the left-hand side. In the middle, we have the low dose, and then high dose on the right-hand side. All of these outcomes, it did show slowing down in the rate of decline in both cognition and function in 4 of those outcomes. I'm going to read those numbers, the reduction, out loud, because I'm going to repeat that in other studies as well to just give you a sense. So 22% effect on CDR sum of boxes, MMSE 18%, ADAS-Cog 27%, and ADCS 40%. So, of course, these are all statistically significant, but very modest clinical effect. Again, just please remember those numbers. I'm going to repeat that later on. So this is about the negative study, Engage trial. And as you can see, in Engage trial, essentially this study was negative. There was really no change in those 4 different outcomes. Now, I need to give a little bit of a background. What happened in these 2 studies, FDA did not allow the sponsor to put people who had genetic predisposition with ApoE4 positivity to go on the highest dose for several months. And then after that, they agreed. So in the middle of this trial, they started to put people on the highest dose, people who had ApoE for positivity. So Biogen actually claims that one of the reasons that this study was negative was because of different exposure to the highest dose in those two different studies. People on this study, the negative study, they were not on high dose enough. So that's a claim that Biogen has brought up. We don't really know, and I don't think that we will ever know whether that's true or not, but FDA looked at that as well. So as you can see here, they looked at these two trials, and the positive trial is in light blue and the negative trial is in green or dark blue, I would say. So they divided to people in different doses of maximum dose of 10 milligram, or the 0 doses, 1 to 7 dose of 10 milligram, and then over 8 doses of 10 milligram. And what they found that people on both of these two studies, that if they had more than 8 doses of 10 milligram medication, they both became positive. So the result came back positive. But again, this is just a claim, and we don't really know whether that's true or not. Now, if you put all of those different trials on the same metric, this is what we have. Here in this horizontal line, we do have the amyloid reduction. The left is better. And then on the vertical line, we have the memory test. The lower is the better. If you take a look at the PRIME trial, the phase 2 trial in red, you can see on the top right, starting with 1 milligram per kilogram, and then 3 milligram, and then 6 milligram, and then 10 milligram, there is a nice dose-dependent reduction of amyloid and also cognitive decline. So essentially, it did what it was supposed to do. If you take a look at the phase 3 trial, the positive one in green, the low dose is somewhere in the middle, and the high dose is on the lower left, where we like it to be. But if you take a look at the negative study, phase 3 negative study in blue, the low dose is where it's supposed to be, but as you see, the high dose is not there. So that actually makes us to pause about the results. Now, let's take a look at lecanemab. This is about the amyloid target removal. So they had phase 2 trial, 854 participants, 18 months of trial. In black line, that's people in placebo, and then 5 different doses. And there was a very nice dose-dependent reduction of amyloid protein in the brain. 81% of people on the highest dose became amyloid negative after 18 months. Again, very powerful medicine. Biologically, it did what it was supposed to do. If you take a look at the clinical outcome here, 3 of them, ADCOMS, ADAS-Cog, and CDR sum of boxes, you can see that the highest dose, there was a reduction. Again, I'm going to read those numbers: 30%, 47%, 26%, something between 20% to 40, 50% reduction in the, or slowing down the rate of decline. Here's again putting all of those different doses under one metric. Horizontal line, again, that's the amyloid deposition in the brain, and vertical line, that's the memory test. Lower left is the best. If you start from upper right with 2.5 milligram biweekly dose, and then 5 milligram monthly, and then 5 milligram biweekly, come to 10 milligram per month, and then 10 milligram biweekly, you can see a very nice dose-dependent reduction in the amount of amyloid, and also slowing down in the rate of cognitive decline. Now, here's about the target engagement of both amyloid and tau. So on the left-hand side, what you see, that's about the amyloid imaging, the amyloid PET imaging. And on the right-hand side, that's the tau. So if you take a look at the left-hand panel, this is when people were started on medication or placebo in black and medication in green. You can see a very nice reduction in the amount of amyloid deposition in the brain. And at this point, they stopped the study. There was a 24 months gap. And if you take a look at the gap period, people who were on medicine in green, there was a little bit of a buildup of plaque in the brain, but not really that much. And then here at this point, after 24 months of gap, they invited everyone to the study, and they started them on medication. People who were on medication before, they were restarted. People who were on placebo, they were started on medication, on lecanemab. And you can see a very nice reduction of amyloid plaques in the brain in the placebo group by even 3 months. So that was a very nice reduction. So it did what it was supposed to do biologically. If you take a look at the right panel, here's when they started, and this is about the plasma p-tau, which is very much correlated with CSF p-tau and or tau or imaging studies. So here they started people on medication. As you can see in green, people on medicine, they responded, and the amount of tau decreased significantly in the brain. And then there was, of course, a gap period. And then after a gap period, people who were on placebo were started on medication. And again, you see a very nice reduction in the amount of tau in the CSF. So again, it did biologically what it was supposed to do, bringing down amyloid directly and indirectly, reducing the amount of tau in the CSF and brain. So the results of open label extension shows that amyloid reduction achieved within 12 weeks. 43% of people became amyloid negative. 81% became amyloid negative by 18 months. Clinical efficacy started within 24 weeks, and clinical treatment differences retained after 24 months of discontinuation. So essentially, when they brought them back for open label extension, when they did the memory test, still people who were on medication 24 months ago, they did better on memory test. Let's talk about donanemab. Here's Trailblazer study, which was again phase 2 trial. It's a very interesting design that they had. So what you see here, 257 participants, and in the lower line in gray, that's 126 people in placebo, and then 131 in green on medication. So they had a titration of 700 milligram after 3 doses, went up to 1400 milligram. Everyone went up to 1400 milligram. And then at 24 weeks, they did repeated amyloid imaging. So they did a quantitative measurements, and the quantitative measurements, the unit is centiloid. When the centiloid in the amyloid imaging is under 25, that's negative study. So at week 24, people who had centiloid of less than 11, very much negative, they were blindly put on placebo. No one actually knew. So people under 11 centiloid put on placebo, and people who had centiloid of between 11 and 25, they were continued on 700, reduction of those 700 milligram, and people who didn't really respond that much continued on 1400 milligram. Then they repeated the amyloid imaging at week 52, and people at that point, people who had centiloid of less than 11, again, they were blindly changed to placebo, and people who had centiloid of between 11 to 25 twice, they were put on placebo. So here's the result in terms of amyloid target removal. What you can see on the left in gray, that's on the top line, that's the placebo, and you can see a very nice reduction in the amount of amyloid plaques in the brain by week 24. Essentially, 40% of people by week 24, they became amyloid negative, 60% by week 52, and 68% by week 76 became amyloid negative. Again, very strong medication. It did biologically what it was supposed to do. Now here, because that was more of a recent study, they did have tau PET imaging, which is kind of more exciting to me because you can see the tau plaques or tangles in the brain. So they looked at 3 different lobes, temporal lobe, parietal, and frontal. And then they divided subjects into placebo and people who had partial amyloid clearance in solid or dark green, and then people who had complete amyloid clearance in dotted green. And as you can see, there was a very nice dose-dependent reduction in the amount of tau deposition in the brain in those 3 different lobes. So again, this medicine didn't really target tau, but by targeting amyloid, they were able to show that the amount of tau will decrease as well in the brain. Here's about the clinical endpoints. So there are 5 of them, Again, I'm going to read just out loud the slowness. So they have, of course, IDRS, ADAS-Cog, IDCS, ADL, CDR sum of boxes, and MMSC. And the reduction was 39%, 32%, 23%, 23%, and 21%. Again, very similar to the numbers that I gave on lecanemab and aducanumab. The other interesting thing that they did, they also looked at those people who became amyloid negative, very negative, less than 11 centiloid. And of course, by week 24, those people, they were put on placebo. After 1 year, up to the week of 76, there was really no that much of accumulation of amyloid. And they did a calculation and they came up with this magic number of it probably takes more than 14 years before plaque reaccumulates to baseline level. So it seems that, again, by removing the plaque, the effect may stay there for a long period of time. Here's about the plasma p-tau, which has a very nice correlation with CSF, amyloid and tau, and also amyloid PET imaging. On the left-hand side, that's the amyloid removal, as I shown before, very nice removal. On the right-hand side, you see the p-tau 217 in the plasma. In the gray line, that's of course placebo, and the solid green line, that's the people who were on medication continuously, and dotted green line, those are people who were switched to placebo after 24 weeks. And as you can see, there was really not that much of change in the plasma p-tau compared to people who continued to be on medication. So that was also very, very exciting result. Now, you probably have heard of that saying that if we torture the data, it will finally confess. So in other words, maybe if we use different types of statistical analysis, we may come up with positivity in our result. So, or the other way around, it would be like, what if I do my own statistical analysis, you do your own, can we come up with the same result? So John Davis Sparks did a very, very interesting analysis. He looked at the Bayesian analysis on two outcomes, the IDRS and CDR sum of boxes, which is the disease progression model. And then he also looked at, frequentist analysis, 4 of them. And you don't really need to be a statistician, as I am not. But when I'm looking from like bird's eye view, I can see that they're kind of the same. Those lines diverge and they look very much the same. So essentially, no matter what type of statistical analysis he used, he came up with the same conclusion about the efficacy of the medication. So donanemab results showed that rapid and robust decrease in amyloid plaque levels, sustained without significant reaccumulation over 1 year of treatment. And after 6 months of donanemab treatment, participants with greater plaque clearance showed less tau progression in frontal, parietal, and temporal lobes, and also greater amyloid plaque changes associated with less cognitive decline. So essentially, it did what it was supposed to do. Let's talk about the last one, which is the gantenerumab. Well, for gantenerumab, we don't really have that much of data. So essentially what has happened with Roche, within the last 10, 12 years, they have changed the dosing of gantenerumab based on the study results that they had. And finally, they came up with the right dosing right now for those 2 studies that are in phase 3 clinical trial, both of graduate studies. So they have probably the right dose. But here's just to show you in Scarlet Road, which was a phase 3 clinical trial, it was a negative trial, about the target engagement. On the top line, as you can see, these are axial images. And these are 5 different patients, and those are amyloid plaques in the brain in hot metallic color. And you can see on the bottom row, after week 104, people had decreased amyloid deposition in the brain. So the medicine did biologically what it was supposed to do. Now, here's just to take a look at Scarlet Road phase 3 post-hoc analysis. And as you can see, there was a dose-dependent response in terms of cognitive issues. So there were more cognitive slowing of cognitive decline if people were on higher dose, and even their open label extension shows much, much stronger results. So anti-amyloid monoclonal antibodies as a class, they are consistently active biologically and effective in decreasing amyloid and tau pathologies in the brain. The overall evidence shows slowing down the rate of cognitive and functional decline, and the clinical effect is dose dependent and correlates with the amount of amyloid and tau removal, it seems, but the clinical effect is modest. Again, when you take a look at those percentage, statistically, those are significant, but if you take a look at clinical meaningfulness, the clinical effect is really weak and modest. So now the question is, what are the reasons for these modest responses? Could it be because of the insensitivity of our measurement tools that we use? It's been now 10, 15, 20, 30 years that we've been using CDR sum of boxes, ADAS-Cog, ADCS, ADL. And if you take a look at MMSE, this actually came out in 1975. So we are very close to 50 years. So these are, again, time-sensitive, very, very good tools at their own time, but maybe now they are too blunt to detect the changes that we are expecting at the level that we are intervening. The other thing is about the multiple co-pathologies, and I will touch base on that in a few slides. The other issue could be stage of the disease that we are intervening. So maybe the symptomatic stage of MCR or mild AD, that's quite late because we already see the neurodegeneration at this stage of MCR very, very clearly. And maybe we need to move a little bit earlier at the preclinical stage. So we may notice some stronger response if you move kind of a little bit earlier. The other thing is the short duration of our trials. If you think about preclinical Alzheimer's, from the time that people start to build up plaques in the brain to the time that they develop memory loss, they become symptomatic, it's 15, 20 years. So now imagine if we are just only intervening for a year and a half or 2 years, how much of change we are going to really see clinically in our patients. Now, let's take a look at our tools that we use, the questionnaires, the tools that we use for outcomes. So if you take a look at effects of disease-modifying agents, those are complex. So disease-modifying agents, they have some effect on global skills, cognitive skills, and functional skills. And maybe by looking at these different measurements separately, maybe that's not the right thing. Maybe we really should use composite scores. And there are ways of using composite scores when we do clinical trials. So now, Sam Dixon did a very interesting job and presented that in November of last year. He looked at 10 different clinical trials, more recent clinical trials of aducanumab, lecanemab, and also solanezumab. And as you can see here, there are 3 different cognitive measurements and functional measurements that we used. By just looking at this graph, you can see that's quite messy. It's all over the place. And although the result overall seems to be positive, but this is quite messy. So what he did, he came up with a z-score of combination of these different tools, and that would be the result. And you can see that this is much, much more clear in terms of the outcome. So maybe we really need to change the type of tools that we use, and we may need to use the composite scores rather than individual scores. Now, I'm going to just digress here for a second because this is so important. I couldn't really help myself. I put a couple of slides. There is a problem with our current randomized clinical trials design because these trials are sequentially and then drug by drug. We use the first drug. If it doesn't really work, we go to second, third, fourth, and then severity stage by severity stage, MCI, mild, moderate, and severe. And they take much too long. If you take a look at a phase 3 clinical trial, the average would be between 5 to 7 years to finish. And they're quite expensive. Maybe the solution is using platform design trials. And this is really something that is coming to right now to practice. When I say practice, of course, research. So the platform trials, it's somewhere between a completely joint study and individual studies of several different drugs. So they can share design in terms of operations, simplify protocol writing, assessment schedule, protocol training, so on and so forth. And also, very importantly, sharing of placebo subjects. So then reducing resources and allowing more subjects to be on medication. And that's something quite significant. Now, Adam Boxer from Alzheimer's Clinical Trial Consortium, that we actually collaborate with them on the HEAD 345 study, he came up with this protocol for Alzheimer's tau platform design, and he has submitted that to NIA, and we are hoping to be part of this study as well if they get the approval. As you can see here, this is a kind of trial platform that they have 6 different arms rather than 2. On the top, you see the placebo, 150 people, and then we have one medicine, anti-amyloid medicine. We have another anti-tau medicine separately, and then we have anti-amyloid and anti-tau medicine 1 together, and then we have anti-tau medicine 2 separately, and then we have anti-amyloid, anti-tau medicine number 2 collectively. So as you can see here, instead of like using 450 placebo group, it's just only 150, and we have quite a few different arms. So that hopefully will reduce the amount of cost and effort and will be much, much faster to come with the right result. So now, if you do all of these different things, like for example, using sophisticated outcome measures and so on and so forth, do we think that we can impact clinically, meaning can we increase the amount of clinical impact? But probably not. And the reason for that is Alzheimer's disease is not alone. If you take a look at a patient with dementia, they do have a combination of mosaic protein aggregates from sparse, moderate to extensive of, for example, beta amyloid, tau, TDP43, and alpha-synuclein. If you take a look at on the left-hand side, so this kind of explains that concept. Again, these are based on studies. So when patient comes and we diagnose with Alzheimer's, it's mainly based on the predominant type of pathology that they have, but they may have other co-pathologies as well. So here on the left-hand side on the top panel B, brain B, you can see that's a patient with Alzheimer's disease because it has predominantly amyloid and tau, but that patient has TDP43 as well. On the right top, the C panel, you can see that frontotemporal lobe dementia patient because they do have TDP43, they do have tau, but they do have some amyloid and alpha-synuclein as well in the brain. If you take a look at the left lower one, Lewy body dementia, the major or the main pathology is alpha-synuclein, but the patient has TDP43 and tau as well. So again, it seems to be a mosaic of different types of pathologies that they come together, and we do see that in neuropathological studies. So let's talk about a few of them. Now, just to give you a background, when people come to my memory clinic, 15% of them, they do have mixed Alzheimer's plus Lewy body dementia. And the way that we diagnose Lewy body dementia is mainly clinically, because these people, when they become with the diagnosis of Alzheimer's and they have Parkinsonism, those core clinical criteria, 4 core clinical criteria for diagnosis of Lewy body, they have either Parkinsonism or visual hallucinations, vivid visual hallucinations, or REM sleep behavior disorder or fluctuation of cognition. So we can easily diagnose them with Lewy body dementia. But 10, 20, 30% of patients may have the culprit of Lewy body, the alpha-synuclein, but they may not be symptomatic and we may actually miss them. Now, in this study, they looked at effects of hippocampal alpha-synuclein on memory. So on the left hand side, when you see these bars, they looked at memory tests, and it seems that alpha-synuclein in hippocampus and entorhinal cortex, it does affect both verbal and non-verbal memory. So that could be a co-pathology that we miss because we don't really have a good biomarker for that. Now, how about TDP-43? And this is another kid in the block. So in this study, Keith Joseph from the Mayo Clinic looked at people who were diagnosed clinically and then neuropathologically. So all of these data are neuropathological data. Looked at the brain of these people and found in 57% of those people who were diagnosed with Alzheimer's and they had the pathology of Alzheimer's, the amyloid and tau, they had TDP-43 as well, 57% of them. And as you can see here on the right panel, those red dots, those are TDP-43. So he controlled the memory test for the amyloid, tau, alpha-synuclein, and vascular issues. Still, TDP-43 had a significant effect on those memory tests. What you see here on the left-hand panel, that's about people with preclinical Alzheimer's disease. So essentially, horizontal line, that's the Braak stage of Alzheimer's. And you can see that people at stage 4, Braak stage 4, who have preclinical Alzheimer's, if they didn't have TDP-43, 40% of them were normal. They didn't have any memory problem. But if they did have TDP-43, that number dropped from 40% prevalence to 4% prevalence. So TDP-43 is a significant player in cognitive disorders. Now, another entity, limbic predominant age-related TDP-43 encephalopathy or late. Again, this is about TDP-43, but this is mainly in the limbic system, either amygdala or hippocampus, and then maybe frontal cortex. And that also shows that people may have this one, and that mimics Alzheimer's disease very, very closely. I do have some patients that I think that probably they do have late disease because the biomarkers for Alzheimer's are negative. So again, this is also quite real, and this could be a co-pathology. And if that's not enough, how about argyrophilic grain disease and underestimated tauopathy? So, and if you take a look at people at the age of 65, about 10% of them, 9 to 10% of them, they do have AGD. And if you come to the age of 100, over 30% of people will have AGD. And this is also another real problem. And some people think that this is the second most common neurodegenerative disorder in the brain when people get older. So again, another important factor that seems to be quite real, and we don't really have anything to measure. And by the way, what you see on the right-hand side, on the lower one, that's a pretangle, which is different from tangle. And then we have the argyrophilic grain on the top panel. Now, and if that is not enough, how about the prevalence of vascular disease in addition to Alzheimer's disease? This is a study from Rush University, Ross MAP study. They looked, again, this is in neuropathological studies. They looked at the brain and they divided people, and these are people who all had Alzheimer's disease pathology in the brain and had Alzheimer's disease diagnosis. And they looked at the atherosclerosis alone, arteriosclerosis only, and then combination with infarcts, those dashed lines. So only 20% of people who had Alzheimer's disease had no significant vascular issues. 78% of patients with Alzheimer's disease had vascular issues. Now, it's kind of interesting because the year after, Charles DeCarli and Julie Schneider looked at the same study, and they added few other vascular entities, for example, cerebral microbleeds or small vessel disease. And what they found was quite striking. At the stage of MCI, only 7% of patients had pure Alzheimer's disease. 93% of people had Alzheimer's plus vascular issues. If you take a look at the dementia stage, that number even dropped to only 3%. So 97% of people had Alzheimer's plus vascular co-pathologies, which is quite actually significant. So that brings me to this slide. When people come to my memory clinic, let's say an 80, 81-year-old person, and I do my assessment, the physical examination, our neuropsychological testing, imaging studies, including MRI, amyloid, tau, CSF, analysis, and we come up with a diagnosis in that person. And for example, we find that patient has amyloid, and then patient has tau. We diagnose that person with Alzheimer's disease. And then we do our MRI, we see some vascular issues as well. That's as much as we can do right now. But as I kind of explained, there are other co-pathologies that are quite significant, including alpha-synuclein, including TDP-43, including argyrophilic grain disease, including hippocampal sclerosis, which is different from TDP-43, including progressive age-related tauopathy part, and quite a few others that we don't even know. So you can imagine, Alzheimer's disease is just only on the top, the amyloid and tau. And if I just only target these two pathologies, amyloid or tau, or maybe a combination, how much of gain clinically I'm going to obtain, considering the totality of these different co-pathologies that patients have. So the good thing is that we do have right now the biomarkers for amyloid. We have very strong biomarkers, the amyloid PET scan, 95% positivity and confidence that patient has, or even if they don't have negative predictive value, the same as well. And CSF as well, the same. And then of course, tau, we do have the PET scan, and we have the CSF, and now the PET scan, the tau PET has become FDA approved. We use it actually actively in clinical trials right now that we have ongoing. And of course, for vascular, we do have the MRI as well. And that's very powerful as well. We can detect and diagnose patients with vascular etiologies for the majority, for the most part. But we don't have anything on alpha-synuclein or TDP-43 or argyrophilic grain disease. So the work is actually ongoing, and especially on CSF to find some new biomarkers for these. In fact, we at EVMS, we started a new center, Integrated Neurodegenerative Disorder Center, and that's mainly about Alzheimer's disease and Parkinson's disease biomarkers. And we started our study this year, which is quite exciting for us. And of course, for others, we don't even know what they are, and we don't have any biomarkers for them. So if you're going to treat, we should really think about this as a totality. Treat amyloid, hopefully treat tau when we have effective medications, hopefully treat vascular if they are present, and also other co-pathologies that are going on. So maybe we can get much more robust clinical outcome in these patients. So that brings me to the conclusion. So I hope that I was able to convince, based on evidence, that anti-amyloid monoclonal antibodies, they seem to consistently reduce amyloid plaques and tau pathology, but they have very modest impact on clinical outcome. And we should really acknowledge that Alzheimer's pathology is not alone in the majority of our patients. There are other neuropathological entities, the co-pathologies that I just showed, that are really contributing into the field as well. Now, work to do. I think we should consider multiple neuropathological comorbidities again by pursuing other drug targets, for example, tau, for example, TDP-43, and so on and so forth. So hopefully we'll be able to ultimately have combination therapy, something very similar to what we have for HIV or for diabetes or for hypertension. We start with one medicine, add second, third, fourth, in order to have quite good impact. So I think we are on the right track, and that's where the field is right now, moving more of combination therapy, hopefully when we have more effective treatments on different co-pathologies. The other thing that I wanted to mention is about the trial duration. As I said, mainly our trial duration is about 18 months, maximum of 2 years. And if you take a look at the incubation period for MCI, progression to dementia, that's about 3 years. And then if you also think about the effect of these neuropathological hallmarks of Alzheimer's on brain, that takes again 15 to 20 years that they have been in the brain and they have made some major changes. You can imagine that how much of impact are we going to have if we have just only 18 months of trial. So hopefully with the platform trials, we will be able to extend our duration of our trials, maybe 2, 3, maybe 4 years. In fact, for example, for a AHEAD 3-4-5 study that right now we have, that's a 4-year trial because that's in asymptomatic people, and they probably need more time to be part of the trials. The other thing is the stage of disease, time of intervention, symptomatic versus asymptomatic. So maybe MCI is too late, because at the stage of MCI, when we take a look at the brain, when we do the MRI imaging, we see significant amount of atrophy, which is neurodegeneration. When we take a look at the CSF, we see significant amount of total tau, and that's as well, meaning that there's neurodegeneration going on. So maybe we need to move a little bit earlier to have quite significant impact on the disease processes. So that's where where the field goes. In fact, the AHEAD 3-4-5 study is the first that is really targeting people who are at the primary prevention rather than secondary prevention. So people that we are enrolling, some of them, the amount of amyloid deposition in the brain is not to the point that we even call them positive. So I think that's really the right direction to go, maybe earlier, to have much higher and bigger impact. And again, last thing but not least is the current trials measurements, which I think are blunt. So we need much more sensitive and robust and continuous objective measurements, because these measurements are mainly snapshots that we do. We repeat them, but they are snapshots, and they may not be quite accurate. And the field is going that way. So there are quite a few different digital biomarkers we actually use for our CBD study. We use wearables and sensors, which is quite interesting. And I think that's where the future is. So with that said, I'm going to stop. Here's actually our clinical Glennan Center research team who work entirely, all of them tirelessly on different projects. And here, just to share with you some of the projects that we have. We have for caregivers. We have a couple of projects for agitation, as I said, for CBD oil, and that's a THC-free CBD oil. And of course, the AHEAD 3-4-5, another trial for the diagnostic studies as well. I'm going to stop here and stop sharing my slides, and I'll be more than happy to answer any questions.
Thank you, Dr. Okhravi. That was really, really good. Appreciate it. Dr. Syme is here. She's our department chair as well. And I think actually today is match day also, isn't that right? I think there was a number of, for our medical students at least, I think today is match day. Or tomorrow?
I think is match day tomorrow. Tomorrow, yep, tomorrow. So we're all with bated breath and much excitement. So thank you for a great talk. I really empathize with the difficulty of long-term clinical trials. My own area is pulmonary fibrosis, and we're just desperate for the biomarker that will allow us to do trials in much shorter time. Can you comment a little bit on some of the novel biomarkers that the FDA might be willing to take on board and use? I think that's always a challenge of, we can identify biomarkers, but getting them acceptable in terms of confidence from the FDA is always a challenge. So I wonder what your thoughts are.
Sure. Actually, that is such an exciting field right now. And I can't tell you that how exponentially the field moves forward. In fact, there is right now one that is approved, which is called Precivity AD, and that's out of Washington University. Randy Bateman and I think a couple of other people, David Holtzman, own that. And this is quite good. This is, again, plasma biomarker. We use it for a AHEAD 3-4-5 study, and it's about 80–82% prediction, the accuracy. And what they do plasma A-beta 42 or 40, and also factor in the age and ApoE4. Now, much more exciting news is about plasma P217. So that's the tau. And I showed in one of the studies. There was a study which is called Biofinder, and I really encourage audience to look into that. It's just amazing study. It's a big study, both US and European. So they had a couple of thousands of participants. And this P217, plasma tau 217, this is quite accurate. This corroborates 94-95% with the amyloid imaging and also tau. So again, if you can imagine, this is a tau biomarker, but that corroborates very, very highly with the amyloid PET imaging and amyloid CSF and also tau CSF. Now, I think that is going to be the future. Probably within the next 2 or 3 years, we will have that available, because right now they're working on the standardization. As you know, it is very, very difficult to come up with a standardized protocol, but that's where actually the field is going. And I think in 2 or 3 years from now, our primary care physicians will have something very, very powerful to be able to screen people and then be able to address this issue much, much earlier. So essentially for those plasma biomarkers right now, we use it in clinical trials. I hope that I answered your question.
Yeah, no, that's great. Thank you. Appreciate it.
Looks like we have a question in the chat here. Secondary analysis of the Fourier trial suggested that much lower lipid levels, LDL-C less than 10, were protective against cardiovascular disease. If vascular disease is a major component of dementia, would you agree that we may want to consider lowering cholesterol esters? There does not seem to be a too low for lipid lowering in the newer studies. You feel differently from a cerebrovascular dementia standpoint?
Yeah, and that's a very new concept, with in the field, and I think that the field has realized that we really need to work on other components as well. And I agree with the question. In fact, now there are quite a few studies that they are combining vascular and Alzheimer's treatment together. There's a study that probably we're going to be a site, and we're using one of the medications for diabetes, which seems to help both Alzheimer's and diabetes. So I think within the next few years, we're going to see combination of different modalities, especially with the platform trials. Let's say anti-amyloid, anti-tau, and then maybe a cholesterol lowering agent to impact much more powerful. The issue is to find maybe the first and second effective medication and then add them on in different studies and see if we can have some synergistic effect of combination medication.
Thank you. One more question in the chat here. What's your opinion on the use of PDE5 phosphodiesterase inhibitors for Alzheimer's disease?
Yeah, there are some some data available, but of course it's not really quite robust in terms of the reproducibility. But that's another interesting area that there are some studies going on.
And one more question in the Q&A here. Dr. Schwartz was saying, any comments about adverse events in the CNS from immune complexes that form there?
Yes. So again, unfortunately, I didn't really have time to really go through that. That's a very, very good question. It's about, of course, ARIA, amyloid-related imaging abnormalities that happens. This is actually quite common. So if you take a look at aducanumab trial, overall, 35% of people developed ARIA, and that's 2 different types, either swelling or edema or cerebral microhemorrhages. But the thing is, before, like 10 years ago, we were quite scared of this side effects, but now that's not really the case anymore, because majority of people are, first of all, asymptomatic, and the only reason that we can figure it out and detect that is just doing sequential MRIs. And 25% of people become symptomatic, and symptoms are headaches, usually nausea, vomiting, headaches, maybe confusion, and some dizzy spells. Those are the majority of symptoms. And in the aducanumab trial, only 6% of people had to stop the medicine. 94% of people who developed this side effects, they were able to continue medication. And by the way, maybe those people who have ARIA, they may respond better. There is some evidence that those, of course, people who have, for example, genetic predisposition with ApoE4, they do have higher rates of ARIA, but they may respond better. So there was a meta-analysis. I actually advised people to take a look. It was just published a few weeks ago, maybe a few days ago. And this is about, I think, 15,000 people throughout the history of anti-amyloid medications within the last 15 years. And it actually shows how common they are and how severe or not. So it's a very, very interesting systematic review and meta-analysis. So, and by the way, some of these medications, they have much, much less of ARIA. For example, if you take a look at lecanemab, that is only 10 to 15% rather than 35%.
Thank you so much, Dr. Okhravi. We are at the top of the hour now, and I just want to thank Dr. Okhravi on behalf of Department of Medicine. Thank you for a wonderful presentation and a really excellent translational medicine here, painting a picture for what's to come. It's very exciting. So, Dr. Syme, any closing remarks?
No, great, terrific grand rounds, evidence-based and very practical, and just loved it. Thank you so much. Appreciate your talents and your time.
Thank you very much for having me.
Thank you so much, Dr. Okhravi. Hope you have a wonderful afternoon. Rest of everybody, we have the CME code is in the chat. Hope you all have a wonderful day. Happy Thanksgiving, not Thanksgiving, St. Patrick's Day, excuse me.
Thank you very much.
Close enough, it's cause for celebration, right?
Thank you all so much. Take care. Have a wonderful afternoon.